I'm Ruth Zielinski. Kathy, you and I have a lot in common because I've not been a midwife quite as long as you, but that's only because I went back a little bit later in my career. I grew up in the United Arab Emirates and I knew I wanted to be a midwife. I worked with midwives there. My parents worked at a mission hospital. And when I came back to the US in 1979, they said, "Oh, we don't use midwives here. You're going to have to go to medical school if you want to deliver babies." And I knew that that was not for me, but I started pre-medicine and ended up thinking this is definitely not for me, but I could love being a nurse. So I went to nursing school, and right about the time I graduated, I was pregnant and found a midwife in Kalamazoo, and where I live in Michigan. And she said, University of Michigan is starting a midwifery program. And I was so excited about that. So with three young children, 30 years ago, I started here at University of Michigan to be a midwife and finished and worked as a midwife. And then 10 years later, came back to get my PhD, really so that I could teach. I was honestly embarrassed. I'm embarrassed to say I told them I wasn't interested in research. I wanted a PhD so I could teach. But they admitted me anyway. And so I then taught undergraduate nursing after finishing my PhD. And then the opportunity 10 years ago to teach midwifery came back to me here at University of Michigan again, and I jumped at the chance because it really is where my heart is. And Kathy, you said your last baby was 8 months ago, and I stopped doing births here in the U.S. about 3 years ago. A little bit over 3 years ago, because it was right pre-pandemic, because I was doing a lot of global work with students and supporting them in doing clinical work. And it was just getting to be too much, but I really, really do miss it. I shared this picture with you because this is my daughter. My daughter finished midwifery school a year and a half ago. She came here. Ours is the only non-distance program in the area. So she was a strong student. She was admitted, and she texted me a few months ago to say, "Mom, I have a patient here, and you delivered her 21 years ago." So her mom is in the picture as well. Her mom was 17, came in completely dilated, had a baby 20 minutes later, and went on to get a master's degree in social work and had her daughter, Serena, who then came in and had this little baby boy, and my daughter was her midwife. So I just think I'm really thrilled that for this opportunity, because midwifery is the oldest profession. Midwifery is so global and so very needed. So I understand that this hopefully will also pertain to people who are teaching in nursing. But like I said, I am glad that there's midwifery faculty, because my examples are all about midwifery. All right. So our objectives, we want to talk about and think about kind of what is the appropriate approach to simulation, depending on what our objectives are. And then I'm just going to share with you, I will say I'm not an expert on simulation, but we've worked really hard on how we incorporate psychomotor skills and communication skills, critical thinking skills into our clinical courses in the midwifery program. I love history, so I got a little sidetracked with looking up the history of simulation. A couple of interesting things I found is that there was a young woman who drowned herself over 200 years ago in the Seine River in France, and they never did identify her, but the coroner was so struck by her peaceful face that he made a mask of her face. And that mask was the model for the first Recessa Annie. So in 1960, when they first came out with resuscitation mannequins for CPR, that was her face. So I thought that was really interesting. And that some of the first simulators were obstetric simulators. And here I have a picture of one that's from the 18th century. I cannot imagine how much time it took to make something like that. And I'm also pretty impressed with how realistic it really is. So when we think about simulation, a lot of times we think about it as kind of the typical, we have some sort of simulator, we have a facilitator or a faculty member, and then we have a small group of learners and they're working on a clinical case. But really, simulation is a whole array of methods that we use for teaching, especially in clinical courses like nursing and midwifery. So it could be just one person, one learner practicing a skill on their own, or it could be all the way to a cross-disciplinary team that's preparing themselves for a birth of quintuplets that's due to take place soon at a large hospital. It really depends on what the objectives are, what your approach should be. So I'm sure that, with all of the other education and seminars, the formative, which is practice. So trying to make that not a stressful testing environment for students. And I know with my students, often they'll get anxious until we really try to reassure them, this is about practice. Nobody is testing you. Nobody's grading you. And I've moved now through a suggestion of one of my colleagues to using more the word practice instead of simulation when we're not in a testing situation. And then there's the summative, which is the evaluation, which obviously is also really necessary. When you think about midwifery education or nursing education, we don't always have the opportunities for students that we need so that we can assess their readiness to practice. And midwifery education in the United States is competency-based. We tell this to our students all the time because they want to know, well, how many hours do I need to be in clinical? Well, you could be in clinical for 12 hours and not one single thing happens, or you could have 5 deliveries. And so, it takes hours, and then it takes, it takes the events to happen. They have to catch a certain number of babies. They have to do a certain number of newborn exams, but it's difficult to always assess, especially when they're with different preceptors or instructors in the hospitals, to know really, are they at the level they need to be to meet competence. I'm going to talk for a moment about high fidelity versus low fidelity, because I am a strong supporter of more low fidelity. When we first opened the new simulation center here, I was fairly new as faculty, and they said, okay, what simulators do you want? And I said, I don't want any of the high fidelity ones that are mechanized, that you have to plug in, that talk, that breathe. I don't want those, because I knew from colleagues who'd worked with them for a long time how often they malfunction. And indeed, now there's starting to be some research that there was one interesting study, I have the reference at the end for you, on teaching advanced cardiac life support. And they had 2 groups. One had all high fidelity mannequins that were very fancy. And the other group had the low fidelity or basic sorts of instructional task trainers. And what they found was, when they measured confidence, the group that had been using the high fidelity were more confident in their skills, but they were actually less competent than the low fidelity. So I thought that was really interesting. And so I just want to, just acknowledge my bias that when I can avoid high fidelity, I do. Even here, where we have a lovely simulation center, they did buy 2 high fidelity birthing mannequins. We did try to use them for a short time. And when we would go over there, they would maybe work twice for 2 groups of students, and then they would stop working. I was particularly frustrated with how they would deliver a breech, because I would have to tell the students, you need to pull on the breech, which we know is not the thing that you should be doing in real life. So we switched completely to low fidelity, and nobody really uses them at all anymore. All right, so thinking about what are your goals for your simulation? What is it you need to achieve? And I'm going to kind of go through these as I go through the different examples that I'm going to give. And then how will you assess goal achievement? Will it be students' assessment, or will it be faculty assessment? Will it be, how will you make that more objective? Can the learners meet the goals through simulation? And they can't always meet their goals. Maybe they can partially meet the goal. Why should you achieve this goal? And is it the right place in the program for this goal and for the simulation? And then you want to link the approach that you use for simulation or for practice to your goal. So, simulation is increasing in clinical education. There's no doubt about that. And that can be a good thing. Here in the United States, there are an increasing number of nursing programs. There's a nursing shortage, so there's more nursing programs. But the big problem with that is there are limited numbers of clinical sites. A lot of the clinical sites will take students, but they're not allowed to even take vital signs or administer medications. There's a lot of patient safety initiatives around errors that happen in facilities and in hospitals. And while these are good initiatives, they have decreased the amount of care that students can give, or it's limited it to observation. There's clinical faculty shortages, certainly in nursing and also in midwifery. And a lot of times students don't have access to medical records now that they're electronic. So students are not really very well prepared to get that background information in order to care for patients. So for all of these reasons, it's increasing, but there are certainly pitfalls in simulation. First of all, it's not real. We should not kid ourselves that this is real. We can make it realistic by certain approaches, but it's not going to simulate a real situation such as a shoulder dystocia, where you truly know that the life of a newborn and the welfare of the mother is in our hands. It's expensive. This is one of the mannequins we have, and my understanding is it was about $60,000. And then the upkeep to those mannequins when they stop working. It takes a lot of organization, just having a simulation experience and having everybody crowd into the space is not going to work. You really have to organize. And even with the best organization, it's always a stressor. There's always something that goes wrong. It's time consuming for faculty. And then it also requires upkeep. You have to make sure that what your approach is current best evidence-based practice. So, for example, if I'm still teaching that, patients should get, say, misoprostol orally for active management of third stage, but the clinical practice is switched to IV or IM oxytocin, then I should know that. I should update every year those simulation scenarios so that I'm not outdated. All right, so we're starting kind of from the beginning. So thinking about kind of progression through one of our midwifery courses. So thinking about just a skill that they need to learn prior to entering clinical practice. And so like for nursing, this might be administering an intramuscular injection. I don't know about all of you, but we learned first on oranges. And then I'm old enough to say that we then practiced on each other. That no longer happens in the US, which I can understand why, but it also was a good way to learn also how patients are feeling. So I'm going to use the example of microscope skills for midwives. So before you even get to the skills practice, having course content readings, perhaps you can find some course content videos. And then, like, for example, for microscope skills, we also have a short classroom lecture that we will have. And then how can they practice? And for this, obviously, in the lab where we have microscopes, but then also they can practice at home with, say, some printouts, printouts of different things that you would see under a slide. So in going back to our goals, so what do we need to achieve? That's microscope skills for midwives. And then because this is a practice and this is it's a formative approach to this. It will be student self-assessment on whether they've achieved the goals or whether they need to practice some more. Students can meet the goals partially through simulation because they're not going to be competent in microscope skills until they've had more practice in the clinical setting. Why should we achieve this goal? Because we do need to practice these skills before we go into clinical. And then when we do it before they start clinical. But I'm using this example because they had this skill practice over a year ago. And what we're hearing from our clinical preceptors is that the students have forgotten the skills. So we had a little refresher. And so linking the approach to the goal, we're going to use a classroom space. We need some microscopes, not many supplies, just some slides, slip covers, some saline, and some swabs. And then one faculty familiar with microscopy. And then the students will depend kind of on how many microscopes we have available. And so then we adjust accordingly. So hopefully you'll be able to hear this.
Yeah. So the first thing I'm going to have you do is go to the restroom with a test tube and a swab and collect some of your own vaginal flora. You do not have to have anybody else look at your slide. So for HIPAA purposes, to protect that, but I want you to look at your slides. You want to get enough of a sample that you'll have something to look at. So you want to make sure that you're really swabbing the insides of your vaginal walls, about an inch or so inside. Swab them, you're.
All right. So in this example, I just want to first say that all of the students and faculty gave permission for me to use these clips, and they were actually really eager to participate. When it's a testing situation, I've done a simulation of a simulation because I didn't want to put any added anxiety on students. So this being a practice situation, it didn't matter. The students did use their own vaginal flora for looking under the microscope. We still do that because that's the best way for them to learn how to identify different types of vaginitis or normal lactobacillus. All right, so now moving on, before our students start clinical rotations, we do need to know that they have a basic level of understanding of and a basic competency in the skills. So this is summative, and the students understand that, and I'm going to kind of go through how we prepare them. But yes, it is anxiety producing for them. For this, we have the students one-to-one with faculty. So we use different spaces. It's somewhat in the clinical learning center, their simulation center, but we also use like office spaces depending on what that skill is. The students may need remediation, and they understand that if they don't perform acceptably or safely in the first round, then they do need to practice and come back before they can go to clinical. So again, this is anxiety producing for students, but it is sometimes necessary for that to happen. We do need to assess the safety before they're in clinical. We do it prior to each clinical rotation. And we can use offices or classrooms as much as we can. We use the low fidelity task trainers. We might need some more supplies like suture, etc. And depending on how you schedule this, you have one faculty for 4 to 5 students. So we do have small classes here, but I do ask for volunteers from, say, the midwives who work over at the hospital and other hospitals in the area. And a lot of times they're midwives who've graduated from our program, and they volunteer to come in and help with this. What we do is they're provided a step-by-step what we expect for them to be able to either verbalize or demonstrate for us. So they get all of this. We use the midwifery textbook, and we go through according to that midwifery textbook, understanding that there are different approaches to things, but we try to teach them at the beginning, like, okay, this is the way for testing situations that we're going to ask you to do this. Then making a schedule. This is one of the most challenging things for me, is figuring out a schedule so that each student is able to rotate through these different stations with different faculty. It always takes me a few tries before I get it right. And then we have a checkoff sheet. Beforehand, if it's faculty or volunteers who have not worked with us before, I go through this. I kind of demonstrate to them what we're looking for. And a lot of times, honestly, most of our students pass the first time. If they get a must remediate, then often it's because they're nervous, they're anxious. And so that faculty will talk them through it again, and then they'll come to me or one of the other full-time faculties for another opportunity. Rarely does it happen that they actually need to go home and come back a few days later. All right, so this is actually one of my faculty members who's demonstrating how we go through this. And we only have one of these birth task trainers. It's low fidelity and it's very portable, which is great.
Give me little pushes as the head is born. Good. So once the head is born, I'm just going to check for a nuchal. I don't find a nuchal. The head of the baby is going to restitute, which we're going to just do with our hands, but you would not do that in real life. You would let the baby do that on its own. Then I'm going to shift myself so that my fingers face my baby's face. Then I'm just going to very gently bring the baby's ear to the shoulder, which will deliver the anterior shoulder here. And then I'm going to bring the baby down, slide my hands down, and bring the baby up. And the baby is delivered. Then I'm going to do active management of third stage of labor. So I'm going to ask my nurse to start the Pitocin. I'm going to place my non-dominant hand onto mom's uterus, feeling for it, and to change from a long watermelon shape or discoid into a globular or round shape like a grapefruit. I have also already got my blood for my cord blood. I'm feeling, I bring my hand back to brace, and I'm doing some controlled cord traction on the cord. I notice that my cord has extended and that my placenta's come down and that I have a gush of blood, and I now have a grapefruit-sized placenta. And the placenta's going to be delivered, so I'm going to help guide that. I might have mom push just a little bit gently with me, and I'll have the placenta come down. And then I gently bring my hand to catch it as I bring the placenta. Good. Give me.
So in that simulation, what I like that birth simulator, but you can't demonstrate delayed cord clamping because the cord is not actually attached to the newborn. But in that example, for example, if she hadn't verbalized that I would do delayed cord clamping, that might be something I would mention on the comments, but I would not make her remediate for something like that. All right, so now moving on, this is another example from our interpartum course. And so they've been in clinical, they've been doing births, and now it's time to kind of move from the normal to the more complicated events. So this again goes back to it's a practice situation, it's not a summative. But we do need to have them practice those things that might not happen regularly in clinical situations, but they certainly need to be ready for. And so again, this would be the students that we get student reflections, and we actually have them do a short survey on whether they felt it was helpful. Often we hear back from students, we want more practice time. They can partially meet the goals through simulation. We would not be able to necessarily say that they are proficient in these skills, but that they would be partially. We do this because these are events that may not occur in clinical practice. Again, we do it in mid-semester. We use birth task trainers that we can do in the classroom or in a office setting or the lab. We don't use a whole lot of supplies, so it's fairly inexpensive. And again, we make a rotation schedule. So you want to think about maybe one faculty per 4 to 5 students. Otherwise, you're there for a very long time. For this one, we actually have students in groups of 2 or often 3, so that everybody gets an opportunity to be the midwife, and that they also get the opportunity to be the nurse and perhaps the support person. So this is an example of our last schedule. And so these are students, and they did agree to the use of this video.
Head pushing. Slow, slow. All right, so it looks like we have the shoulder. Can we do Miss Roberts? I'll start the timer. And suprapubic pressure from maternal right. Stop, reposition. Okay, for the anterior shoulder. Give me a good push, Matt. Right.
All right, so in this case, we do just a short debriefing afterward. And, I ask the students, okay, do you have any suggestions? And in this case, suggestion was don't forget to call for help. But otherwise, each of the students get an opportunity at least once. Often they ask for one more week for shoulder dystocia, because it is something that they may have already actually encountered in clinical with their preceptor. We do breech, we do postpartum hemorrhage, which again is a more common occurrence than we would like it to be. Shoulder dystocia, cord prolapse. Those are the things that we do. All right, I wanted to talk about something that we're really trying to incorporate that I'm really excited about, and that's peer-to-peer simulation. I have a little quote: the remarkable feature of the evidence is that the biggest effects on student learning occur when students become their own teachers. So what I noticed a lot of times is that when we got students into groups with the precept, with the faculty, the students had ideas that had come from their clinical practice, from their readings, from their experiences, and they were really learning from each other. And this is a really collaborative and safe learning environment. So some of the benefits are, again, that students are able to learn from each other. Students feel a lot less performance anxiety because of this. And it gives you more flexibility with time and space, because you don't necessarily need faculty there. So, and it also frees up the faculty, and it's relatively inexpensive. So we have been incorporating more of this peer-to-peer simulation. So again, this is formative. It can be summative. There are, Lirdal's working on a program that would actually provide feedback to faculty from students' assessment through an app on their phone. So it could be, but right now for us, it's completely formative. We get feedback from students on whether it was helpful, whether it made them feel more confident. Again, this isn't going to completely meet the goal of being competent. It is less stressful for students and frees up the faculty time. We do it throughout the program. And again, it can be used in other spaces. We even have students check out the task trainers and take them home. So then you don't really need faculty unless you're doing it as a summative sort of thing. So here's one that students, this was a practice that students did and we recorded.
Feel the urge to push? It's a lot of pressure. Okay, so it's new. Okay, awesome. Well, are you okay? This is your heart rate, and then just make sure everything is regulated. Definitely. I'm gonna feel for the people back. Maybe it's really kind of everyone understand. You're gonna put gloves on and check your cervix. Are you comfortable like this? Do you want to get? That's the pressure fused. Yeah. Okay. Oh, so, a little bit of pressure here, okay? Yeah, your cervix is all the way gone, like complete, and maybe it's right here. Right? Just gonna give you some good, strong pushes. There might be a time at the end where I tell you to slow down and kind of pant through the pushes. Just slowly be silent. You're feeling all of it. So when you feel that pressure, go ahead and push right into it. And then you have another one coming on. Just help slow things down. You do look great. You're doing great. Oh, it's got lots of hair. Good. The baby's head is out. Is restituting. Here you go. Look at it. Oh, so cute. Time of birth is 1629. Here's a little thing from the kids. You like the cry? Wow. You did awesome. Look how beautiful he is. Oh, so beautiful. Another ball. Use some oxytocin here to put in your thigh. This helps prevent excess bleeding after birth. Are you okay with that? You might notice some cramping afterwards, but that's actually what I want to happen. And tell me if you start feeling some pressure like another thing in there. That's the placenta getting ready to come out. You're all right. Everything looks.
All right. So with this, you'll notice that what we were really focusing on was respectful care during birth. We weren't focusing on actual skills. So you look at like the way she gave the injection, obviously that's not how you would give an injection. She's not wearing gloves because we try to not waste things like gloves, but how she asked permission for doing things. That's what we were really looking for, because what we find is sometimes in the middle of the program, when they've been in clinical sites where maybe they've not seen such respectful care, getting them back to that basics of making sure that you provide respectful care. All right. So lastly, the observed structured clinical examination, or OSCE, which I don't really like the name, but I can't think of anything better. So this is where you really would want to determine, has this person achieved competency? So the example I'm going to give you, and it's not that every student needs to do every one of these. We do one on, pregnancy loss, on intimate partner violence, or breastfeeding counseling. And so they don't know necessarily what all they're going to get, but we have a few scenarios that they get ready for. And this would be a faculty assessment to determine if they have achieved competency. And it's done toward the end of their class or their program. And again, this would require a schedule for this. So I'm going to give you an example. Again, this is a student who graduated last spring. She's finishing her doctorate of nursing practice. So it's just an example. It's not an actual testing situation. You'll notice it's back again in my office.
Hi, Sophia. Hi. My name is Cameron. I am a midwife that will be caring for you today. Oh, so nice to meet you. How are things going? Okay. Okay. Tell me more about, congratulations, by the way, baby girl. Yeah, so it sounds like, you had quite the, labor and delivery experience. Tell me about how all that went.
It wasn't what I thought it was going to be. It wasn't like I planned it to be, but we got little Ruth here, so.
Well, I'm glad and I'm so happy that Ruth is doing well and you're doing well now, but that can be very difficult to not have a labor and delivery experience that you planned on. It's hard.
Yeah, I thought I had everything planned out. I thought it was going to be a lot easier. I mean, everybody does this, so I just thought it was going to go.
I'm sorry that you ended up having a delivery experience that wasn't what you anticipated. Tell me about how the first couple weeks postpartum have been.
Well, I'm doing okay. I'm still sore from the surgery and all, but I have lots of support. My husband's very supportive. My work has been very supportive. They've sent food over. My mother and mother-in-law have all been supportive too. I'm having a lot of hard time with feeding her.
Okay, tell me more about how you're feeding her and kind of the struggles that you've been facing.
I'm an investment banker. I'm in charge of a lot of people. I can handle anything, but I failed at the birth, and now I'm failing at feeding her. She doesn't want to nurse very well, and everybody can do this. Anybody can do this, but I can't do it.
Oh, I'm sorry. You're not failing her. I know it feels that way, and breastfeeding can be so hard physically, but also emotionally and mentally. So you are not alone in that.
Yeah, it's just been really hard.
Yes. I'm so sorry, Sophia. I'm glad that you're here today and coming in so we can kind of talk about this a little bit more and hopefully help you feel a little.
All right, so obviously this would go on a little bit longer, but I just wanted to show you a little bit of what, and the student would get the chart at the door so they're able to look at it, but briefly, and then go through the visit, which we would observe either in the room. So in this case, you can use like a standardized patient, but standardized patients are a little bit costly. So what we do often is we actually serve as the standardized patient, and then we're able to actually assess while we're doing it. So it decreases the cost a bit for the students. It's not perfect, but then again, nothing is. And this was one of the faculty. She was laughing. She's like, I think I'm too old for this, but that's the thing about simulation. It's not going to be totally realistic. All right. So we talked about pitfalls. Now kind of how to maybe avoid some of those pitfalls. And again, acknowledging that it's not real. It's practice for the real thing, and hopefully there'll be parts of it that are realistic and that they're going to remember. We talk a lot about muscle memory. So when they're, for example, practicing their suturing skills, then they get to clinical and they'll say, but this is on a real patient. They're uncomfortable. They're bleeding. It doesn't look like the foam or the beef tongue that we use, but hopefully they've done enough practice that they at least have that muscle memory to remember the knot ties, remember their hands position and the instruments and things like that. Ask yourself if there's less expensive alternatives. You don't necessarily need expensive things for practice. You can use, for example, you can use a sock with an orange inside that's had some of the peel cut out for students to practice their vaginal exams in labor. Preparing ahead of time, this is one thing that I've really learned. It takes a lot of time ahead of time, and then it runs more smoothly. Keeping it simple at the same time, it is less time consuming. If you keep it simple, you don't always need a complicated scenario. Think about what you really want the students to achieve and what you have to do to achieve it. And then reviewing your content regularly for changes in guidelines, like I said before, so you're not teaching them something that actually is no longer done. Just for our own future goals, one thing I've not been very successful in is interprofessional practice. So working with other providers, such as the physicians, and that's really just because it's complicated getting everybody's schedules together. People are at different times in their programs, and just finding spaces, incorporating more peer-to-peer practice. And then the other thing I've started doing this fall is actually having the students use their hands to learn certain skills. I got some modeling clay and got tiny little baby dolls, and they all modeled their own pelvises so that they could practice like the cardinal movements of labor and different fetal positions. And that just is an easy thing to add in, and is fairly simple. So we'll see how the student feedback to that is. My references again, as I said, and then now it's time really for any questions you might have. So I'm going to stop sharing my screen and comments, feedback, questions.
Thank you very much, Ruth. That was even as a non-midwife, that was great. My brain was going for my workshops as I was watching. So this is actually the best part of these, is to have the presentations that get us all thinking, but then really have a chance to talk peer-to-peer, educator to educator about this. So I'll open this up for questions from anyone. If you're feeling shy, you can type them, but just unmute and have a conversation works well too.
Hi, Valerie here. Thank you. It was an excellent presentation, very informative, and I enjoyed it from beginning to start.
Oh.
A question that I have is, how regular do you said that after each simulation, you sit down and do a follow-up with the student individually, or it is a group session?
That's a great question. We don't always do follow-up after every simulation. So for example, when they're doing skills practice, like the microscope, or say they're doing suturing practice, then we don't do a follow-up. When it's a group, like for the, the high stakes, low frequency, like breech or shoulder dystocia, we just debrief quickly in the room. And then afterward, we meet the whole, we don't have a large class, so we'll meet afterwards, maybe for a few minutes. When it's a testing situation, then we would meet individually with the student to talk to them. What I don't do currently is record the OSCEs, even though we have that that capability. I know that that's something that people do as far as recording, and we just rather take notes and then talk to the students about what they did well. I am considering recording only because sometimes then it's a little bit more objective, because students might say, but I did that. And when you watch the video, then they can see that they didn't do it. So considering doing that, it just adds another layer of complication, but sometimes it's worth it. The other thing we do that's not related to simulation is because our students are in clinical all over the state of Michigan. They have to drive sometimes, 1 to 2 hours. We meet once a week for class. And as part of that class, we do clinical conference. And that works again for them to, reflect on what's happened in clinical, because sometimes they say things that are uncomfortable. People talk about patients in the way they shouldn't, or they don't ask for permission and things like that. So that's something that I think is really important, that we give them a chance to debrief from their clinical experiences outside of that hospital, because sometimes it's hard as a student. I still remember being a student, and you feel a little bit powerless in that. One of our students was telling us that the resident made a crude joke, and she said, I don't think that's funny. And later her midwife preceptor said, don't say that to them. We need to work with them. So we need to maintain a good relationship, and you making them feel uncomfortable. So we were able to listen to her, and, because it was distressing. It was a crude joke. It should not have been said. At my age, with my experience, I can say something, but students can't. So I think that it's really helpful to incorporate that also.
I have another question.
Sure.
So in terms of the OSCE, doing the OSCEs, I remember seeing a presentation done on the OSCEs, and the person was saying to the evaluator that was evaluating the students, you are the fly on the wall, because they were going to assist. So the person was saying all the time, you are a fly on the wall, you are a fly on the wall. But I see in your presentation, you said like you intervene, like if they're going to harm the patient, or if it is a step that should be there, for example, delay cord clamping, then after you will have a discussion about it. So a little conversation about they say in OSCE be the fly on the wall, and when do you intervene?
This is the thing about us midwives, right? Or maybe not you, but we always think we do things differently, because you're right. I don't follow the rigid, because I think that it's the whole point is for students to learn. So yes, it's a testing situation, and I wouldn't stop them during it, but definitely talk to them afterward. Again, because we don't always use standardized patients, I might not be the fly on the wall. I might be I might be the standardized patient in that situation. So perhaps not ideal. Again, so that is, you make a really good point that maybe I do need to think of a different term, because the true OSCE format is you are the fly on the wall and you don't say anything. And so we try to follow a lot of the same principles, but again, so I would talk to a student immediately after, particularly if they did not perform well enough to pass, because I think it's really, immediate feedback is so much better than getting feedback a day or 2 days later. So I would try to give them feedback right away. There are times when maybe it's somebody who's not full-time faculty, and they might feel like they need to reach out to one of us full-time faculty. Like, look, this is what the student did. I'm concerned about that. And so then we would talk to them that day rather than waiting. Did you have anything to add, Megan, from your experience?
Well, so we do things two ways. So if something is designated a learning situation, for the ones that I do, and now I'm in primary care, for the ones that I do in the primary care courses that are designed as learning situations, I do actually stay quiet until the end, but I have gone from debriefing it together as a group a week later to making sure to set aside 5 minutes at least for individualized feedback right afterwards. And actually, when we're using actors as patients, we found that the feedback coming from the actor is great because the student still sees that actor as their patient, right? Mm-hmm. You watch them for 5 minutes, they're aware that we're watching, they're aware it's fake. And then somewhere in there, they start just listening to the person and examining the person and trying to communicate with the person. And they briefly forget, right? And so when they come right out of it, they're still thinking of that person as their patient. So if their patient says, it worked really well when you did this, I noticed that I was concerned about that, and I told you I was concerned about it, but then you never asked me more questions about it. So we've gone to some immediate feedback and then a little bit as a group for collective. I also do some antepartum assessment teaching, but for a group of students where it's really just to help them take their textbook learning about what is antepartum care, what happens during pregnancy, and help them apply it, not on an exam, but in a scenario. So that one is not a graded one because these are not midwifery students. I'm not expecting them to be able to go out and do it on their own, but they need to know, what would the person be worried about? How would you assess in the second trimester? People will show up, with a sore throat in primary care, and they'll be pregnant and something will be going on, and the whole system is safer if we in primary care can recognize what should be happening, what's abnormal. And so that one I do as almost a peer learning, right? Where the students are, I give the healthcare provider, the one who's playing the provider, a chart, a paper chart with information. I give the one who's playing the patient some more information, and I have them walk through the visit, including measuring, including we wear those abdomens that Ruth students were wearing. But on that one, I do debrief it immediately as well. I don't interrupt though. I do it right after.
I would agree. I try to not interrupt whenever there's more of a scenario. If they're just practicing a skill, I think that's different. But, and again, I think there's a lot of value to having students be the patients, not so much in testing situations, but in learning situations, in practice situations, because it's important as midwives and nurses and nurse practitioners that we also kind of have that experience of being more vulnerable. So that's something we do. And that's what I like about the Mama Natalie's and the Mama Birthies is that they give you the chance to do that. You can use them on the table as well, as just a regular birth task trainer, but we do use them a lot, wearing them both for like the antenatal sorts of things and also interpartum.
What other questions came up for you?
Or comments or ideas that you found work?
I just wanted to say that I found that the briefing was essential after any simulation or clinical practice skills. Um, thanks for explaining that it's really best when we are testing a student not to be interrupting. But even but there's a difference between when they're just practicing the skill versus when they are being tested, and that's important. But what I wanted to ask was the preparation, because it seems as if you spend a lot of time in the clinical, well, not the clinical space, but before they go out in clinical. It seems that way to me. I could be wrong, but that's something we don't necessarily have a lot of, which is the preclinical time. So your preparation, your scenarios, do you have those all set up for you already? Do you have a schedule? Do you have, it sounds like it's all very, very organized, like your
Oh, I wish.
teaching sessions would be for classroom.
It's funny because I was
Okay,
just
how do you overcome, how do you,
I was
yeah.
just we do twice a year, we do a meeting where the directors of midwifery education, there's I think 49 programs now in the US. So we're a small enough group that we try to get together twice a year in person. And one of my colleagues who's at University of Minnesota, she's like, "Oh, I have the clinical learning center people do all of that for me." And I was like, "Oh my goodness," because we don't have that capability here. So I don't because I'm not a naturally organized person. That's why I really, I mentioned that it's so important because I've learned from my mistakes. Like you can't just have it like, oh, well, we're going to have you start here and go, like I put signs up on the doors now and things, and there's still confusion. Like, oh, that group was supposed to go there and they went there. And then the other thing that happens is, people come volunteer, they come to help. And then they're so happy to see other people. They just start talking amongst themselves because, as midwives, we work separately from each other. And we do try to prepare. And the reason is because our students are by themselves out in clinical. It's a little different than nursing school is here. And I don't know as far as like midwifery education in Barbados, but, our students are just with, we might have 4 students at University of Michigan Hospital, but they're never there at the same time. So they're there. And so they, and one of us is not there. So having them have kind of a base knowledge of the skills and the normal, and even then they will be in a situation and their preceptor might say, well, what do you mean you don't know, what to do if this happens? And it's like, well, we haven't covered that yet. So that's what I think our because our education is a little unique in that way, we really try. And student feedback, because consistently every year when we do evaluations of the programs, they say we want more practice. That's why, because it is so time consuming, trying to work more peer-to-peer simulation and practice in, and trying to to minimize the time our students are in lecture, although they really like that too. So trying to figure all of that out.
Thanks, thank you.
Yeah, that was a great question. It might be helpful to know just sort of what is sort of the pattern, because I know midwifery will occasionally have semesters where you will have your students on campus a lot at the beginning of the term and then out in clinical. Whereas the program that I teach in, most of the courses, they are, in clinical practice several times a week, every week, and in lecture every week. I know midwifery has done some different things over the years, so I'm just curious what the current pattern is for you guys. So do you still bring them like for an intensive week at the beginning of each term or not anymore?
Are you asking me, Megan?
Yeah.
Oh, yeah. Yeah, we do 2 weeks of intensive. And we actually added a whole course before they go into clinical because what we were hearing with other midwifery programs, like our preceptors, the midwives who are out there helping the students, is that they were no longer taking students from some programs because they felt like the students weren't prepared enough for clinical. So that's why we really thought, okay, we need to make sure our students are well prepared. So we do 2 weeks at the beginning of every semester where they're here 3 days, 3 long days. And then we still meet throughout the semester. Like I said, this is the intrapartum semester, and we meet once a week for class for 8 hours. And, now we're covering more of the complications. This Friday, they have an exam, and then we do newborn complications. We'll also do, like I was saying, we do the clinical conference where they can talk about their clinical experience. And we've started breaking that up into smaller groups rather than have the whole class. This class, there's only 14. Next year, there's 21. So breaking it up into smaller groups with each, so it means all the faculty have to be here. But it seems to be helping to have kind of that smaller group dynamic where they can share what's happening for them.
Yeah, I think it's great getting the feedback from the students regularly. I think that's, very, very essential. And they also, I hope they feel that you care, having faculty present. Must help them feel very supported.
It's not always easy getting student feedback. Sometimes I get a bit defensive, or it's like, okay, that's not possible. But yeah, it is important. And again, it can be challenging getting student feedback. That was one thing that was suggested to us, is that we actually get feedback after every class. And that has been helpful, but again, sometimes it's not easy to read,
I think Dr. Watson Miller has a hand up.
Yes, thank you. Apologies, multitasking, but I did see some of the presentation and I really truly enjoyed the presentation. Going to the question that you asked, Megan, our curriculum for midwifery is presently being revised right now. But previously, we used to send the students after, like, we will have 4 intense weeks in the clinical setting for 3 days. And then we would send the students out in that semester afterwards. So we used to do the same thing that you did. Even in the clinical setting, we try to do a post-conference. We try to meet with the students after that day in the clinical area so that we could see what was their feedback, how they felt about any clinical issues that they might have, and discuss the client that they might have had too as well. But previously we did, in the beginning of the semester, we will have 4 intense weeks before going out into the clinical setting. But we are presently revising our curriculum right now.
That sounds similar. And it's, I don't think there's one perfect way to do it. We, because our students are literally all over the place, we do at least one site visit a semester where we go to that site and see how things are going. But it's not the same as being present there with them, their whole experience. So we really very much rely on our preceptors to give us feedback and support the students. And it doesn't always, it's not always ideal. Sometimes the personalities clash a little bit. but that's life too, right? That's life with working in the working world. So a student might say, my preceptor was mean to me because they told me they just needed to, me to stop talking or something. And it's like, well, yes, that happens.
Hey, Valerie again. What mannequins do you have? Simulators, birthing simulators? What's the name of them? I know you said the mama table.
I I use mostly the mama birthies now. So I have them in my office because I haven't put them away yet. But what I like about them is they're so portable. And so, they're just basically, you strap this on, the baby and the placenta go in. And then what's nice too is you can actually simulate like a uterus that's boggy that then firms up. That's what I think is kind of fun about them. And then it's fairly, nothing is ever going to be really realistic, but the first model was the Mama Natalie's, and it was kind of really hard to get the baby through. This one's easier to get the baby through. The other thing I like about it is it's not delicate. You can literally wash them and dry them and, haul them around. And I really like that a lot. The other one is Sophie and her mom. And what's nice about that is there's an actual pelvis in the model, and then the fetus actually has like a skeleton. So it's really realistic, but it's also they're a little bit more delicate in that I always make sure that I wash it and dry it and powder it, but so real. I went to a conference and they had me practice a shoulder dystocia with it. And my heart was racing. I was sweating. I was anxious. It was so realistic. But they are more expensive too. But with proper care, they do last forever. And they always work because it's operated by the instructor versus, the ones that are mechanical, that I've just never, ever had good success with them. With shoulder dystocia, they are not realistic. They release at the wrong time, or they release not at all. And with breech, you have to pull on them, or they don't work at all. So and this is another thing, I don't know how many midwifery programs you have in Barbados, but we have such a good community of midwifery faculty across the nation that, I'll put an email out and I'll say, hey, what have you had good luck with? And when I asked about birthing simulators 7 years ago, everybody said, don't get the high fidelity ones. And indeed, that's been our experience as well. So, and the other thing is that we as midwives encourage people to birth in different positions. But you cannot do that with the Victorias and the Sim moms. They have to be lying on their back with their, in lithotomy. So, Sonia?
Yes, we just purchased the mama births. We have 2 of those. What I like about them is that it makes the simulation more realistic because you can strap it against someone. I'm here looking at your Sophie mama birth simulator, which I think would be good for teaching them how to palpate and everything. So that's something we could look at, but we do have the mama births right with us.
Yeah, the Sophie and her mom, and there's also Charlie and his mom, and it's a good one for vaginal exams in labor. The students will say, this is really hard. And I'll say it can be really hard in real life too, but it's definitely more, you can do a really posterior cervix or, things like that. But again, we only have one of those. because they're more expensive. So we try to kind of save it for the shoulder dystocia or things like that. And we use the Mama Birthies way more for the same reasons that you do. I totally appreciate that. Well, this has been so fun. I would love to come visit in person. I always love going different places and talking to midwifery faculty and students.
Looks like we have an additional question from Cynthia.
Hey, good morning.
Good morning.
I totally enjoyed the session, and I just want to make a comment about my observation about the benefit of simulation for student midwives. I have been observing student midwives practice and sometimes in the oral and practical examination. And I have found that student midwives exude a lot more confidence when they are exposed to simulation sessions, prior to their actual examination. So, and then another thing, technology has been playing a very major role in the teaching learning environment recently. And the the teacher-centered approach to education, sometimes the students resent. So I find that not resent, but they're not more accepting of this approach. So I find with the inclusion of technology and the simulation, the students actually come alive, and I am extremely happy because in my days of training, they were not always available, and we had to rely on the experience in the clinical areas. So I am extremely happy that these simulators are being provided, and they help not only the learner, but also the person delivering the lessons, and it makes midwifery education a lot more interactive and exciting at this point.
Oh, perfectly said. It's so true. And, what I don't want to see happen is simulation take the place of clinical practice, because there's nothing like being in the clinical setting. But you're absolutely right that just having that confidence of, okay, I've done this in simulation. This is different, but I can do this is huge. And I totally agree with you. Like, students now are not going to necessarily enjoy sitting and we probably didn't either, right? Sitting and just listening to lectures all day. So we tried to, 8 hours is a long day. So that's why we tried to mix it up. So.
Yeah, oh, that was great. And if I'm not mistaken, in Barbados, I know other parts of the Caribbean, the students' exams are actually with real patients, right? Do people go and observe them in the clinical setting? But it is an exam, and I can see where practicing your steps, practicing what you need to remember to say over and over, would really help with the extreme anxiety of being examined when having an examiner there watching you see a real patient, which actually 20 years ago we used to do to our students as well. Our clinical site visits, I watched people, and you could fail your site visit. You could fail by what happened with a patient that you were really seeing. Well, if you're interested in learning more and stuff, we are hopeful as a collaborating center that our next 4 years line of work will end up being working around midwifery curriculum and midwifery education, helping just to provide technical support as midwifery educators look at, changes in curriculum. What do you want to keep? What do you not want to keep? So hopefully we'll be convening even more often in the future.
I hope so too. Thank you so much, everybody, for joining. I know it's, as faculty, you've got so much going on, and I really appreciate it.